Today, we're taking a deep dive into coma. It's a state that's often really misunderstood.
That's right. It's much more complex than just being unconscious.
And getting the details right is absolutely critical, isn't it, for diagnosis, treatment, even predicting outcomes. Misinformation can lead to really serious errors.
Precisely. Which brings us to a key idea. Localization.
Localization. So not like finding your way around town.
Yeah, I know. In neurology, localization means figuring out exactly where in the nervous system the problem is happening.
Okay, so pinpointing the damaged area.
Exactly. It's
Yeah.
fundamental. Knowing where helps us understand why someone's in a coma.
Let's maybe use an example. Our sources mention a patient, Mr. Z. He's motionless.
Right. But if you call his name loudly, he opens his eyes briefly, looks left.
But no response to questions, no following commands.
And that right there shows why terms like coma or stupor or lethargy, well, they're just too vague.
They don't give you that localization piece.
Not at all. They tell you alertness is down, sure, but not how or where the brain isn't working right. What we need is a really detailed description of how the patient responds or doesn't respond to different things: sound, touch, pain.
That detailed picture is key for the medical team to communicate clearly and figure out what's going on.
Absolutely. It drives the whole diagnostic process.
And our sources highlight a few specific states that might get confused with coma, but are actually distinct, like akinetic mutism.
Yes, akinetic mutism. The person appears awake. Their eyes might even be open, but they're silent and they don't move voluntarily.
So they look awake but unresponsive.
Almost. Sometimes the only sign they're aware is that their eyes might track you around the room.
Fascinating. What causes that?
Often it's linked to damage in the frontal lobes, both sides, the parts involved in initiating actions and speech. But it can also happen after, say, severe lack of oxygen, head trauma, or certain strokes.
Okay. Then there's what used to be called the vegetative state.
Right, the terminology has evolved.
Yeah.
We now prefer terms like persistent unresponsiveness or unresponsive wakefulness syndrome.
Unresponsive wakefulness syndrome, what defines that?
It's a complete lack of awareness of self and the environment. But importantly, the patient still has sleep-wake cycles. Their basic bodily functions, breathing, heartbeat, are preserved.
So awake cycles, but no awareness.
Correct. And finally, there's locked-in syndrome.
That one sounds particularly difficult.
It truly is. The person is mute, completely paralyzed, can't move a muscle voluntarily.
But they're awake.
Fully awake and fully aware of everything. It's often caused by a stroke affecting a specific part of the brainstem, the pons, usually due to a clot in the basilar artery.
Wow. Trapped inside their own body.
Exactly. It really highlights how consciousness relies on very specific brain structures and pathways.
So let's talk about those pathways. What's the underlying neuroanatomy of consciousness? Where does it all happen?
Well, our conscious awareness depends on this constant interplay between the cerebral hemispheres, the big outer parts of the brain doing the higher level thinking, and a network deep inside called the Ascending Reticular Activating System, or ARAS.
ARAS, okay.
Think of it like the brain's main power switch for alertness. This was really shown back in 1949 by Maruzzi Magoon in animal studies.
What did they find?
They found that if you damaged this ARAS region in the brainstem, the animals went into a coma-like state. Their brain waves looked like they were asleep, even with strong stimulation.
So damaging that on switch basically turned off alertness.
Precisely, even if the rest of the brain was relatively intact.
Where exactly is this ARI in humans?
It's located in a specific zone, the paramedian tegmental region, in the back part of the pons and the midbrain. So right in the brainstem.
Okay, the core connection point.
Yes,
Yeah.
And it's not just one spot. It's a complex network of fibers. It stretches up to parts of the hypothalamus and the thalamus.
A thalamus, that's like a central relay station, right?
Exactly. The thalamus then sends signals out widely to the cerebral cortex, the outer layer, regulating its activity level. It's this whole interconnected system.
And coming out of coma, is that just flicking the switch back on?
Not quite so simple. Even waking up from anesthesia involves a very specific step-by-step reactivation of different nodes and connections within this brain network.
It sounds incredibly intricate. Our sources mention sedative drugs can interfere with the RAS. How?
Well, many sedatives work, at least partly, by dampening the activity within the RAS. They disrupt the communication, the synaptic transmission between the nerve cells in that system.
So they turn down the volume on the alertness signals.
Essentially, yes. And it's not just drugs. Any major disruption to these alertness systems, like damage from lack of oxygen, for example, leads to big changes in how different brain areas connect and talk to each other. It affects the brain's functional connectivity.
Okay, so that's the basic mechanism. What are the different ways, pathologically speaking, that a coma can actually happen?
There are several main pathways to coma. One big one is a large lesion, like a stroke or tumor, in one cerebral hemisphere that causes the brain tissue to shift.
Pushing things around.
Right, causing pressure and potentially herniation, where parts of the brain get squeezed into spaces they shouldn't be, often compressing the brainstem.
Hmm.
That's very dangerous.
Okay, what else?
You can also have diffuse damage affecting both cerebral hemispheres, widespread injury.
Not just one side.
Correct. Then there are lesions, specifically in the diencephalon, the deep structures like the thalamus and hypothalamus we mentioned, or a lesion in the cerebellum, the structure at the back.
How does the cerebellum cause coma? It's mainly for coordination, right?
It is, but a large cerebellar lesion, like a bleed, can swell and press directly on the brainstem from behind, disrupting the ARAs that way.
Ah, indirect pressure. Makes sense.
Then, of course, you can have damage directly within the brainstem itself, hitting the areas head-on. And finally, conditions like acute hydrocephalus, a rapid buildup of fluid in the brain, can raise pressure everywhere and cause coma.
That covers the how. What about the specific whats? What are the actual diseases or events that lead to coma through these mechanisms?
The list is long, unfortunately.
Hmm.
It reflects how vulnerable the brain can be. First, you have global lack of oxygen or blood flow, global anoxia or ischemia.
Like from a cardiac arrest or drowning?
Exactly. Then there's cerebrovascular disease. This covers massive strokes in the hemispheres, brainstem strokes like a basilar artery occlusion.
The one that can cause locked-in syndrome.
Right. Also brain hemorrhages or even clots in the veins draining the brain, dural venous sinus thrombosis.
Okay, so blood flow problems. What else?
Trauma, obviously. Head injuries causing diffuse axonal injury, widespread nerve fiber damage, or brain swelling, bleeding.
Infections?
Definitely.
Oh.
Meningitis, encephalitis, inflammation of the brain itself, brain abscesses.
And inflammatory conditions like autoimmune issues.
Yes, things like autoimmune encephalitis or vasculitis, where blood vessels in the brain get inflamed. Tumors are another cause, either large ones pressing on things or tumors directly in the brainstem.
We mentioned hydrocephalus.
Acute hydrocephalus, yes. Seizures can cause coma, sometimes even ongoing seizures without obvious convulsions, called non-convulsive status epilepticus.
That sounds hard to spot.
It can be. Then there are toxins. Drug overdoses are common, but also various poisons. Metabolic problems are huge, too.
Well, like what kind of metabolic issues?
Severe imbalances in things like sodium or blood sugar, liver failure, kidney failure, thyroid problems. And finally, even just severe hypothermia getting dangerously cold can induce coma.
It really is a sobering list. So many potential causes. Let's shift now to the patient. When a doctor encounters someone in a coma, how do they even start to figure out which of these might be the cause? What's the examination like?
The clinical exam is absolutely paramount. It has to be systematic, looking at various neurological functions very carefully. The findings guide everything else, what tests to order, what treatments to start.
What are the key things they're assessing?
Several key areas. First, the Glasgow Coma Scale, the GCS. It's a standardized way to score the level of consciousness based on eye-opening, verbal response, and motor response.
Gives an objective number.
Right. Then, temperature, as we'll see, that can offer clues. The respiratory pattern is incredibly important.
How they're breathing.
Exactly. Then, a very close look at eye movements and pupillary responses, size, shape, reaction to light. The corneal reflex, touching the cornea gently to see if they blink. And finally, the overall motor pattern, any spontaneous movement, muscle tone, reflexes to stimuli.
Let's break some of those down. Temperature, you said that gives clues.
It can. Hyperthermia, a high fever, isn't unusual, especially after severe head trauma. Now, they might have an infection causing the fever.
Which is common in hospital settings.
True. But the fever itself can also be neurogenic, meaning it's coming from the brain's own temperature control centers being disrupted. Maybe the hypothalamus or parts of the pons are damaged.
Interesting. And the respiratory pattern, you said that's very important.
Hugely important. The specific way someone is breathing can often point toward the level of damage in the brainstem.
So different patterns suggest different locations.
Often, yes. Though, you have to be careful because metabolic problems can sometimes mess with breathing centers and mimic patterns seen in structural brain injury.
Okay, so what are some of these patterns? Our sources mention post-hyperventilation apnea.
Right. That's where the person stops breathing for a short time after taking several deep breaths. It usually points to mild bilateral dysfunction in the cerebral hemispheres.
How long do they stop breathing?
Normally, after 5 deep breaths, maybe you stop for less than 10 seconds. But with hemispheric issues, that pause, the apnea, can stretch out to 20 or 30 seconds.
Okay. What about Cheyne-Stokes breathing? I feel like I've heard of that.
Yes, Cheyne-Stokes is quite distinct. It's cycles of breathing getting deeper and faster, then getting shallower and slower, and then stopping altogether for a bit apnea before the cycle repeats.
Waxing and waning with pauses.
Exactly. And interestingly, during the faster breathing phase, the patient might actually seem a bit more alert, and their pupils might get a little bigger.
What does Cheyne-Stokes usually mean?
It's often linked to problems deep in the brain, like bilateral thalamic dysfunction. It can also be a warning sign of impending transtentorial herniation, that brain squeezing we talked about.
A bad sign.
Here can be. But it can also be caused by metabolic things, like kidney failure or even heart failure or just lack of oxygen. So seeing it definitely warrants an urgent look for increased pressure in the head.
Okay. What about just rapid breathing, hyperventilation?
Sustained rapid hyperventilation can be seen with injuries in the midbrain or pons. Paradoxically, these patients might still have low oxygen levels despite breathing so fast. Sometimes it's triggered by things like brainstem tumors affecting the local pH around the breathing centers.
And there's some really odd-sounding patterns like apneusistic breathing.
Apneustic breathing is very strange. It's characterized by a long pause after breathing in, holding the breath, then a short breath out. It points to lesions in a specific part of the lower pons, the lateral tegmentum.
And cluster breathing.
Cluster breathing is just what it sounds like, irregular clusters or groups of breaths followed by irregular pauses. That usually suggests damage a bit lower down in the low pons or upper medulla.
Ataxic breathing sounds pretty bad.
It is. Ataxic breathing is completely chaotic and irregular. Breaths vary in depth and rate, with unpredictable periods of apnea. It basically means the brain's respiratory control center is failing.
Where is that damage usually?
Typically in the dorsomedial part of the medulla, the lowest part of the brainstem. You see it with severe events like cerebellar or pontine hemorrhages, bad trauma, or tumors back there. Often it's an agonal pattern, meaning close to death.
There's also Undine's curse. Sounds dramatic.
It does. It refers to the loss of automatic breathing, specifically during sleep. The person breathes okay when awake and consciously thinking about it, but stop when they fall asleep.
Wow, where does that come from?
Lower brainstem dysfunction, often from small strokes in the medulla or sometimes high spinal cord injuries. It highlights that voluntary and automatic breathing have somewhat separate controls.
And one more, central hypoventilation.
This can happen, for instance, after a stroke affecting one side of the lower brainstem. It might knock out both voluntary and automatic breathing control, or just the automatic part, depending on the exact location involving areas like the pontomedullary reticular formation and the nucleus ambiguus.
That's an amazing amount of information just from watching someone breathe. Let's move to the pupils. Doctors always shine lights in the eyes. Why is that so crucial in coma?
The pupils are a fantastic window into brainstem function, specifically the midbrain and the third cranial nerve, which controls constriction. And here's the key. The pupillary light reflex is usually very resistant to metabolic problems.
Meaning, if the pupils aren't reacting properly, especially if one is different from the other, it's more likely a structural problem.
Exactly. Unequal or unreactive pupils strongly point towards a structural issue in the midbrain or affecting that third nerve. Reactive pupils, even if small, in a deeply unresponsive patient, that often leans towards a metabolic cause. It's a critical distinction.
Our sources mention small pupils are common in coma.
They are. Doesn't automatically mean something specific is wrong. One practical point, though. Doctors should avoid using eye drops that dilate the pupils just to look at the back of the eye, because that wipes out this valuable diagnostic sign.
So how can they see the back of the eye if needed?
There's a reflex called the ciliospinal reflex. Pinching the skin on the neck stimulates the sympathetic system and can cause the pupils to dilate briefly, which might be enough.
What about drugs affecting pupils? Can medications mimic brain injury signs?
Some can, yes. Certain drugs, like an older one called glutathione, could cause unequal, poorly reactive pupils. High doses of barbiturates, some muscle relaxants like succinylcholine, severe hypothermia, or acute lack of oxygen can all cause pupils to become unreactive.
And if pupils stay unreactive after something like cardiac arrest?
If they're fixed and dilated for more than a few minutes after an anoxic event, that unfortunately carries a very poor prognosis for recovery.
Are there specific patterns of pupil abnormality that point to specific locations?
Yes, absolutely. In metabolic coma, or with damage to the diencephalon deep inside, you often get small but reactive pupils. sometimes called diencephalic pupils.
Okay. Small but working.
Right. Damage to the hypothalamus on one side can cause a small pupil on that same side, along with lack of sweating, part of Horner's syndrome. Midbrain lesions are interesting.
How so?
If the lesion is in the top part, the tectum or protectum, the light reflex might be gone, but the pupils might spontaneously fluctuate in size, that's called hippus, and still react to that neck pinch. But if the lesion is deeper in the midbrain tegmentum, the pupils are often mid-sized, fixed, maybe even irregular or pear-shaped.
What about lower down? Pons lesions.
Pontine damage, especially hemorrhages, typically causes very small pinpoint pupils because it knocks out the sympathetic pathways that normally dilate the pupil. They might still react slightly to bright light, but they're tiny.
And lesions in the lateral pons or medulla.
Those can also cause Horner's syndrome on the same side. Small pupil, drooping eyelid, decreased sweating.
I've definitely heard of a Hutchinson's pupil. What is that?
Hutchinson's pupil is a classic sign. It's one pupil becoming widely dilated and non-reactive to light.
What causes it?
It's typically caused by compression of the third cranial nerve, the oculomotor nerve. Often this happens during transtentorial herniation, where increased pressure forces part of the temporal lobe, the untias, down, squeezing that nerve against other structures.
A sign of dangerous brain shift.
Yes. And the pupil change often happens before the eye muscles controlled by that nerve become weak.
What happens to the other pupil in that situation?
Interestingly, the opposite pupil might also start to enlarge and become sluggish, maybe fluctuate a bit in size. Changes in that contralateral pupil can actually track how the neurological situation is worsening.
One quick mention from the sources. Guillain-Barré syndrome. How does that fit with pupils?
In very rare, severe cases of Guillain-Barré, the paralysis can be so complete it even affects the pupils, making them unreactive. This could mimic severe brain injury or brain death.
But the brain itself might be okay.
Potentially. An EEG, measuring brain electrical activity, would likely be much more normal in GBS than in severe anoxia, helping differentiate. It's relevant because locked-in syndrome can sometimes arise from variants of GBS too.
Pupils tell a huge story. Let's move to eye movements. How do you assess those if the patient can't follow commands?
Since voluntary eye movements are out, we rely on reflex movements. The main ones are the oculocephalic reflex, the doll's eye maneuver.
Where you turn the head and see if the eyes move oppositely.
Exactly. And the oculovestibular reflex, which involves putting cold or sometimes warm water into the ear canal, caloric testing. That's a stronger stimulus.
What do these reflexes tell you?
If these reflexes are present, it means the pathways connecting the inner ear, the eye movement nerves, and the brainstem structures coordinating them are largely intact, at least from the pons upwards.
What if you just see the eyes moving on their own?
Slow, conjugate, horizontal back-and-forth movements called roving eye movements also suggest the brainstem pathways are intact, but that higher cortical control is impaired. The absence of quick, voluntary eye movements, saccades, combined with these slow, roving movements is typical of coma with an intact brainstem.
What about blinking?
Spontaneous blinking indicates the pontine reticular formation is working. Blinking in response to a bright light involves a pathway through the midbrain superior colliculus. If someone doesn't blink on one side, it might just be a facial nerve problem on that side.
Can the eyelids give clues?
Sometimes. In certain types of pontine stroke, the eyelids might stay wide open, tonically retracted. We call that eyes open coma.
Is there a typical order in which these eye signs disappear as coma deepens?
Generally, yes. The spontaneous roving movements tend to go first, then the doll's eye reflex fails. Finally, the caloric responses disappear. But remember, in metabolic coma, the pupils might still react even when all eye movements are gone.
Are there specific, maybe more unusual eye movement patterns that mean something?
Oh, definitely. Some are quite specific. There's periodic alternating gaze or ping-pong gaze. The eyes slowly sweep horizontally side to side. Often indicates bilateral cerebral damage, but an intact brainstem. Can sometimes see it in metabolic states too.
What else?
Repetitive divergence eyes slowly drift outwards, then quickly jerk back to the middle. Often seen in metabolic encephalopathy. Nystagmoid jerking of just one eye can suggest damage in the mid to lower pons. Very small, rapid eye movements might be seen in non-convulsive status epilepticus.
Ocular bobbing sounds descriptive.
It is. Typical ocular bobbing is a quick, sharp downward movement of both eyes, then a slow drift back up. It's strongly associated with damage within the pons itself.
But it can happen in other conditions?
Yes, sometimes with posterior fossa masses or metabolic issues. If horizontal eye movements are preserved along with the bobbing, that really points to an acute pontine injury. Atypical bobbing, where horizontal movements are gone, is less specific. You can even have bobbing in just one eye, or disconjugate bobbing where they don't move together.
What about bobbing in other directions, inverse or reverse?
Right. Inverse ocular bobbing, or ocular dipping, is the opposite. Slow down, fast up. You see that more with diffuse brain problems like after lack of oxygen or prolonged seizures. Reverse ocular bobbing is fast up. Slow down, seen in metabolic issues, encephalitis, sometimes pontine hemorrhage or drug poisoning. Patients might even show different types at different times.
Slow upward ocular bobbing.
Slow up, fast down. Can be pontine infarcts or diffuse dysfunction. Then there's protectal pseudobobbing. Looks like bobbing, but it's a rhythmic down and in movements, like a V pattern.
Why is that one important?
Because it's often seen in acute hydrocephalus and signals the need for urgent surgery to relieve pressure. It's usually faster than true bobbing.
One more. Vertical ocular myoclonus.
That's continuous, pendular, up and down swinging movements, usually around 2 Hz, often seen in patients who are locked in or comatose after severe pontine strokes, sometimes associated with rhythmic movements of the palate, too.
Goodness, the eyes really are complex mirrors of brain function. Let's turn finally to motor activity. How is that assessed?
We look for any spontaneous movements, we assess muscle tone by moving the limbs passively, and we test reflexes, including responses to painful stimuli. While maybe less precise for pinpointing location than eye signs, motor findings tell us a lot about severity and potential causes.
Like how?
Well, metabolic coma usually doesn't cause weakness on just one side, hemiparesis, whereas a structural lesion like a stroke often does. However, metabolic issues can cause abnormal posturing.
You mean the decorticate and decerebrate posturing?
Exactly. But first, just observing the response to pain is key. Does the patient withdraw appropriately? Do they just posture? Is the response different on one side versus the other? That asymmetry points to a focal problem.
And muscle tone.
Passively lifting a limb, does it fall slowly, suggesting some retained tone? Or does it drop like dead weight, suggesting paralysis or very deep coma? Comparing sides helps detect weakness. There's also a pattern called man-in-the-barrel syndrome.
What's that?
Weakness mainly in both arms, with legs relatively spared. Can happen with lack of oxygen, affecting specific watershed areas in the brain.
Okay, back to the posturing. Decorticate.
Decorticate rigidity, or flexor posturing, is arms pulled in tight to the chest, elbows bent, wrists flexed, while the legs are stiffly extended. This typically indicates damage above the midbrain in the cerebral hemispheres or diencephalon. Can also be seen in severe metabolic dysfunction.
And decerebrate.
Decerebrate rigidity, or extensor posturing, is worse. Arms are extended straight by the sides, wrists rotated inwards, legs stiffly extended, feet pointed down. Sometimes the back arches to opisthotonos. This usually means damage at the level of the midbrain or upper pons.
What were the difference?
It reflects which motor pathways are disrupted. Decerebrate suggests damage below pathways that normally inhibit extension, leaving extensor pathways unopposed.
Can you see both at once?
Yes, if the damage is asymmetrical, you might see decorticate posturing on one side and decerebrate on the other. Or other combinations like arms extending but legs weakly flexing, which points towards the pontine tegmentum. Complete flaccidity, no tone at all, usually implies very low brainstem, medullary damage, or spinal cord injury.
Lastly, our sources mention facial myokemia or some reflexes persisting even when the brainstem seems destroyed.
There have been rare reports of, say, facial twitching, or maybe a flicker of an eyelid reflex in patients thought to have complete brainstem destruction. Sometimes the pathological proof wasn't totally definitive in those cases.
So if there's any doubt about brain death,
Then ancillary tests are crucial, things like EEG to look for any electrical activity, or cerebral blood flow studies to see if blood is even reaching the brain. These provide objective confirmation when the clinical picture isn't perfectly clear.
this has been an incredibly thorough deep dive. From the basic wiring of consciousness with the RIS, through all the potential causes of coma, and down to the nitty-gritty of the exam breathing patterns, pupil changes, eye movements, motor responses.
It really emphasizes how much information can be gathered at the bedside with careful, systematic observation.
It's clear that understanding these mechanisms, what these signs mean, where they localize the problem, it's absolutely critical for managing these incredibly vulnerable patients.
Absolutely. Seemingly subtle signs the exact way the pupils react. A specific twitch in the eye can hold profound diagnostic and prognostic meaning. It really underscores the power of the clinical neurological examination.
And it leaves you thinking about the sheer complexity required just for us to be conscious and aware. Even when that's lost, the body often still holds the clues if we know how to read them. Definitely food for thought.